It's Monday morning, March 9th at 10:06 a.m. and it's already been quite the morning, hasn't it, Kevin?
Both in healthcare news and broader world events, right? Lots going on
Y-
these days, Martin.
Lots going on. I think the place to start is with UHS's Universal Health Services announcement that they're acquiring Talkspace. Wow, did not have that on my bingo card.
Yeah, was not expecting to see that this morning. I It's interesting to see. To me, it's this kind of first provider organization acquiring upstart digital health company. Talkspace is no longer small startup, right? Large public company at the moment. This was a pretty sizable deal for UHS. Interesting move. Certainly was not expecting it, but they were at Lee today and they were kind of talking through their general strategy behind it, which was, listen, we want to get into outpatient behavioral. Talkspace has, I think, 6,000 therapists, and we liked that. That's a good way for us to get into virtual care. It's a good step down from our facility models. Provides a virtual care access point for younger populations, and it provides a referral point for Talkspace into UHS, which at a high level, I get that thesis, right? I think it's interesting. The analyst who was talking to UHS leadership this morning said, what's the employment model for Talkspace? And they're like, most is not W-2. Small portion is W-2, but most of these docs work independent practices for other organizations, which to me is something of the interesting question here for an org like UHS. Like, what are you actually acquiring in that? Be interesting to watch.
A sort of dumb model I have for provider M&A is you look around and say, where can I find a large group of providers and to acquire? Because building out a provider network is very hard, very expensive, and a lot of providers are employed at this point. So yeah, the question of what are they acquiring when most of the therapists aren't employed is a good one. I also have to wonder, the if you look at the premium that Talkspace got, it was not very large, maybe 8 or 9% from where they were trading on Friday before the announcement.
Mhm.
And I'm sure that this is, a favorable outcome from the board of directors standpoint, but it feels a little unsatisfying to me. I don't know. I kind of don't get it from UHS's standpoint. I understand that they're saying, okay, we can like step up and step down, but
Yeah.
I would want, I don't know, talkiatry, which they probably could not get a similar deal on, seems like maybe a more interesting asset to me.
Yeah, it does strike me as a interesting one. To your general point that you made on the model for provider M&A, I think it's worth digital health entrepreneurs thinking about that point. When I was inside health system, right, I was in innovation, there's a biz dev function, and there was a playbook that was 2, 3 inches thick on here's how we bring provider groups into the fold inside of our health system. I think every health system has a biz dev team that knows that playbook, and it centers around, to your point, bringing providers into the fold. So yes, you've got 6,000 docs in a net and that you have affiliations with, I suppose. That's an asset. To your point on talkiatry, that's the central part of their narrative, right? They didn't start with therapists though. They started with psychiatrists, right? And that, to your point, I think is an even more interesting asset here, in part because they have them on W-2 contracts, in part because it's the psychiatry relationship. But yeah, it's interesting to think about. Was not expecting to see that one this morning to kick the week off.
I'm very curious, and I think, I'm going to put a calendar reminder to check in back in a year because I suspect we're going to hear a lot of stories about Talkspace therapists being upset at being employed or quasi-employed by a hospital system.
It'll be interesting to watch. I could see that going both ways, right? Docs inside the health system not exactly loving the relationship. Talkspace docs not exactly loving the relationship. We'll see
Yeah, it could be bidirectional in that way too.
for sure.
The other crazy piece of news this morning, which you hinted at in the newsletter yesterday. So on Friday, we got a news story basically saying Hims and Novo were talking again. And this is been the will they, won't they story of the year or decade, basically. Set the scene for us, Kevin. Like what's the history of this relationship arc?
So it was early last year, right? When they came on their initial partnership, Hims was gonna be distributor of Novo's GLP-1s. Broader context, right? Novo has had its fair share of leadership challenges itself. Its stock price has struggled while Eli Lilly has been taking over the space. Novo came to the table, partnered with Hims for distribution purposes, right? That is what Hims has. There was an earnings call where Hims talked about that is the power that they have that can bring pharma to the table. They've got the brand with the patient and they've got that distribution capability. It's a thesis that makes sense to me. Novo then backed out of the partnership, saying that Hims is doing some untoward things with compounded GLP-1 marketing. They didn't like that, and so they walked away. That was, I think, midsummer, right? And then Hims stock has been hit in part because there's this question of, okay, you're just doing compounded GLP-1s. Um, what are you going to do when the pharma industry decides that they don't like that? That came to a head, of course, a few weeks back when Hims said, we're going to do the compounded pill. Novo said, you're not. The FDA kind of said, you're not. And Novo sued Hims at that point in time. Safe to say, nobody was expecting Novo to come back to the table or Hims to do what they announced this morning, which was Hims announced that they are going to stop, I think, advertising of GLP-1s. So they're not going to include that from an advertising perspective, it seems, or sorry, not just compounded GLP-1s. So they're not going to advertise them. I think it reads like they're still going to be in the platform in the same kind of way that they have been historically, but it's just no longer going to be advertised. Novo has taken its lawsuit off the table, and they're going to start putting Novo's product into Hims later this month, I think, was it? Great outcome for Hims. The news, Bloomberg got wind of the news Friday night, published a report. Stock was up, I think, 40% after hours. I think it's up something like that this morning. I mean, this is a huge win for Hims, from my
A
perspective,
coup. It's a
right?
coup.
I don't know though what Novo is doing here. I mean, I think it's an acknowledgement of the distribution stuff, right? But like, I just don't get it.
What would need to be true for you as a Novo exec to kick the tires on this? Like what are the conditions? I was thinking about this morning and I was like, well, it must be that I'm placing a large bet that Hims is the linchpin, is the crucial asset to get our drugs in the hands of people versus Eli. And even then, man, it's such
Yeah.
a reward for bad behavior that I instinctually am like, I just don't know that even if, someone came to me and made that case and articulated it very well, I would say, okay, but what happens when, I mean, so the statement said, for what is anticipated to be a limited set of customers whose clinical needs cannot be met using the increasingly varied set of commercially available FDA-approved GLP-1s, Hims and Hers plans to offer access to compounded GLP-1s if a provider determines that a compounded product is clinically necessary. That is a loophole you could drive a semi-truck through.
How much time do you think lawyers spent on that? Is that one sentence or two sentences?
It's one long sentence.
That
I
is a very carefully worded sentence in a press release between two parties that have had a on-off relationship.
it's I think it's bad for life sciences. So a thing that I've been fascinated with, and I talked about this in the newsletter last week, is when it makes sense for a member of an industry coalition to do something that does not benefit the entire coalition, to defect from the prisoner's dilemma. I talked about this in the context of Clover and alignment. and their announcement saying, yeah, CMS, the rate notice looks fine to us, which is a little bit baffling unless you are looking from the perspective of alignment and Clover and saying, this is to our strategic advantage. And so even though we're not going to be very popular at industry functions for a little while, this is our like a golden opportunity for us to grow market share and hurt our competitors. This is one of those things where it is in every pharmaceutical company's industry for patent laws to be enforced. And so
Yeah.
this is just a head scratcher.
Yeah. I mean, the only slight modification I'd go back to, like, I don't, it strikes me as Novo, like, rewarding bad behavior. I might modify it to they're willing to overlook bad behavior because they view it as, to your point, it being in their best interest. And I think it's really telling towards the power of Hims' distribution narrative at the moment. Clearly, Novo feels the need to come back to the table on this one when they could go the other direction, litigate Hims, make it known that this sort of behavior is not going to be tolerated in the industry, and partner with other companies like Roe. But the fact that Hims is getting them back to the table to me is indicative of Hims' market power here, right? Like I noticed there's, Hims has its fair share of short sellers at the moment. One of them was on Twitter talking about how this is indicative of Hims not having any differentiation anymore. And I actually, to me, it seems the exact opposite. Sure, I mean, they're going to be selling the same brand of GLP-1s as everybody else, but that wasn't the differentiation point, right? The differentiation point was the brand, which seems like it's more important than ever given this deal. Speaking of interesting relationships, can I mention an earnings call that I was listening to this week that I did
Yes,
not
please.
expect to be listening to? So Wiley, John Wiley and Sons, which is apparently a publisher and research organization. I didn't realize it was publicly traded till last week. Its stock is up 20%, 27% over the last month after very AI-centric earnings call strategy for them as a publisher researcher of interest for this audience because they announced partnership with OpenEvidence last week. And they talked through some of the specifics of that deal, noting that multi-million-dollar contract, and Wiley actually received equity in OpenEvidence as part of the deal. To me, this is fascinating because one of the things that has stuck with me about the OpenEvidence narrative, going back to their JP Morgan presentation in January, is how their CEO Nadler talked about OpenEvidence as the Spotify of healthcare AI. We are going to pay the publishers versus everybody else has been the Napster of AI, and they're just stealing intellectual property. And it's fascinating to me because I've been reading a little bit more on Spotify's early strategy, but early on they gave an 18% equity stake in the business to the key record labels to get the record labels on their side. And this appears to be kind of an ongoing debate as to the merits of that strategy and what that means for the independent artists who are under the brands. But nonetheless, it clearly has worked really well for Spotify. And so I find it fascinating that these are the terms that OpenEvidence is negotiating with these big publishers, where they're giving them equity in OpenEvidence, which presumably makes them more aligned to OpenEvidence's success over time and seems like a really solid strategy for a business like that. So I found it fascinating.
Yeah, I also found fascinating this week. Elevance has been using USB thumb drives.
Going from
And
AI to mailing thumb drives.
well,
Healthcare for you.
it's not the least technologically advanced thing in healthcare. I mean, it's an industry that still uses the fax machine quite a
Yeah,
bit.
they're not sending CD-ROMs at least.
Discuss. Yeah, I haven't thought about USB thumb drives in quite some time. I haven't used one in decades. And so Elevance was trading down this week because CMS announced an action against them. So starting end of March, they've not changed their ways. They won't be allowed to enroll new people in Medicare Advantage. That's bad if you're in the Medicare Advantage business. to a large extent. The story's crazy to me. Since 2018, Elevance, so, risk adjustment, they need to submit their files for risk adjustment. There's an online portal that they're supposed to use. They've been encrypting a thumb drive and I guess mailing it to CMS in Maryland. And that's crazy to do. What's also crazy to me is that CMS just decided to get mad about it now. So this is, 2018 is the first Trump administration, and then 4 years of the Biden administration, and we're a whole year. Open enrollment just wrapped up. We're a whole year into the second Trump administration, and it's like, what are we doing here? I don't like. If I was a regulator, I would. And someone sent me a USB drive when they were supposed to submit something electronically.
Hmm.
I don't think I would wait 8 years. It's baffling to me.
Yeah,
Baffling.
the whole sequence of events here is fascinating to me. From the Are they just putting this in a FedEx envelope and overnighting it to CMS and it just shows up on somebody's desk at CMS and they open it up and put the thumb drive into their computer and
Would not put that thumb drive in my government computer, which yeah, no, not
do
at
they
all.
call them with the password and tell them this is how you unlock the thumb drive? Like what goes on that has been happening for 8 years? One. Two, it's fascinating to me that Elevance in their so they had to file an 8K on this because this was a material thing, right? They lost 6 billion roughly in market cap as a result of this issue. It's a big deal for a company like them. In their 8K, they noted from their point of view, they stopped doing this in 2023. They fixed the internal process.
What does that mean, Kevin, from their
I
point
don't
of
I,
view?
I I don't know
It's either
because
you sent the thumb drive or you didn't.
CMS in their letter noted that it happened again in October 2025. Like that seems like a very straightforward matter of fact that should not result in that discrepancy between CMS issuing a letter and Elevance noting that in their 8K. The other fascinating part of this to me, if you're Elevance, when does this rise up to your leadership team in terms of importance? Like I can imagine back in 2018, there's some team that's just shipping risk adjustment data and it's not a big deal. And maybe CMS sends you a letter that's like, please fix this. But at what point does it get to the CEO's attention that CMS is really unhappy with this and we need to fix it? How many letters does CMS send before that happens? And how does it result in a $6 billion loss in market cap? It's crazy to me. It doesn't seem that hard to fix. Like, why not just submit data via CMS's systems? Why are you still sending USB? I have so many questions, Martin. But in general, it feels like. So we'll talk a little bit throughout this about Chris Klomp's comments last week at the Better Medicare Alliance. One of the things he said, he made this quote I really like about healthcare not driving AI, pile driving it into the ground like it has with other technologies. And he's like, there are three things that need to be true for us to make sure that that doesn't happen. One, interoperability, data. We got to get these stakeholders start sharing data, which to me, I kind of see here, right? It's like, Elevance, we've had enough of this. Time to shape up.
Yeah.
I'm curious how Elevance convinces CMS that it's fixed this at this point, too, by the way, given all
I
of
mean,
that.
I have
Like,
one idea. It would be to stop sending encrypted thumb drives. I don't know how often you need to submit risk adjustment data. I assume it's on an annual basis. Maybe it's quarterly basis.
there's a good OKR for Elevance in that. Zero thumb drive shipped to CMS in 2026.
It's so easy to not. So I go out of my way to not go to FedEx and the post office and, to not ship things. Like if I can do something online, that is my preference. And so this is wild behavior to me. I mean, I guess if you're a big company like Elevance, maybe FedEx comes to you. And so it's a different story. Wild. Okay, where I want to end in the public markets, Ardent, the little hospital operator that could reported or couldn't, as the quarter may be, reported earnings. Nothing wild here. Adjusted EBITDA expectations for 2026, they guided down. it's, they're sort of on the community health system side of the curve where they're in tougher markets. Their payer mix is a little bit worse. What I thought was interesting is, they're the last publicly traded operator to report for Q4 in 2025. And so I play a little game every time a publicly traded hospital operator reports, and I say, okay, they grew revenue. Yes, they did. How much did they grow revenue, and how much did they grow it by price versus volume? And Ardent, like all of the other folks, said, yeah, it was mostly price. And that was an interesting comment last week because Blue Cross Blue Shield released a fascinating analysis, where they're sort of pointing the finger at AI coding intensity. And these two things just rhyme really closely. It's like, yeah, we're
Hmm.
not seeing more patients, we're not getting more efficient. And by the way, when you look at the academic stuff about scribes, they're saying, yeah, they're making doctors a little bit more efficient. Mostly what they're doing, the academic articles don't say this. They say a little bit more efficient, 5, 10, 15 minutes, 5%, whatever it is, less pajama time. But they are really good at finding coding opportunities and ratcheting up intensity. You included a chart from this study that BCBS, who is biased, we should say, they're a payer. I,
Hmm. For
I'm
sure. They've got
I'm not
one lens on it.
saying you should take you should take it at face value, but you included an interesting chart.
Yeah.
Do you want to kind of talk through that chart?
There, so Blue Health Intelligence looked at the commercial inpatient claims for Blue Cross Blue Shield. So that's the data set. They their data suggests that it's 10% of hospitals that are driving this behavior, right? So they had this analysis, it's in the newsletter, um, that showed 10% of hospitals saw a increase of their complex inpatient cases as a percent of total inpatient cases grow from what 47% to 59% over 22 to 2025. So 13% increases during that 3 year period. Meanwhile, the other 90% of hospitals stayed relatively flat. So they were 51% to 55%, which there's what 6,000 hospitals in the US, so 10% of them being 600 hospitals. I It makes sense that there's some organizations to your point, and it also makes sense that they're kind of correlated with being large public organizations that are doing well financially as they see that growth and that change over the last 3 years. It also raises that broader point of the have not dynamic in hospitals and health systems today of if you are undertaking this behavior, it seems like it should be working really well. It seems correlated with the have. If you're not, it seems correlated with the have not. Now, what I also find fascinating in all of this, Klomp, also at that Better Medicare Alliance presentation last week, made the point. He said, we are seeing this, and I think he called it a little worrisome to us, that we're seeing this increase in service intensity by providers without a corresponding increase in outcomes. To me, that is another way of saying exactly what we were just talking about here. He also noted that payers are ramping up in response to that, and we need to figure out a way to calm down kind of the arms race on both sides because ultimately it's not helping reduce costs for anybody. And that's going to be interesting to watch.
Yes. Kevin, what the heck is going on in Idaho?
Oh, this was my favorite story from last week. So, state of Idaho, the state legislature considering new legislation that is essentially targeting one emergency room in the state, a town called Post Falls, Idaho. I think it's right next to Coeur d'Alene. Um,
Beautiful, beautiful place.
Never been, would love to go. So there's one emergency room in Post Falls that Blue Cross Blue Shield of Idaho flagged for the state, I think last year, as being a particularly egregious participant in the No Surprises Act independent dispute resolution process. We have discussed this IDR process uh, at length recently in the community in conversations. Providers, there are at least some of them that are funneling dispute claims through this process as a way to um, from their perspective, get paid a fair amount. From the payer's perspective, increase what they are getting paid in an unfair way. It's interesting because Blue Cross of Idaho shared some of the data of this single emergency department, um, noting that of the 40 emergency departments in Idaho, Blue Cross Blue Shield receives 280 IDR claims per month from this single emergency department, while the other 39 emergency departments submit a collective 14 claims per month between them. So you can tell there are a lot of claims going through this IDR dispute resolution process. Blue Cross also noted this emergency department was seeking to be paid $8,600 in its emergency department for a sprained knee, while the median market price, I think, was $1,700. I had a typo in the newsletter on that number. They seem to be routinely seeking 1,000% of Medicare rates. So it's not one of the provider complaints of the IDR process is that payers are artificially setting rates low, which Medicare is a payer. They are setting rates, but 1,000% of Medicare is a wild number to me. Stepping back, the emergency department is operated by a public company called Nutex Health, which has been building this micro hospital freestanding emergency department model built on the No Surprises Act and the IDR process as a key part of their business model and their business success over the past couple of years. This hasn't come without issues, right? There was a big short seller report back in July last year calling into question how they started this IDR process and funneling claims through it. They have, on their public earnings calls, you can listen to them, they talk all about how this is a key part of their strategy as a business. And from their perspective, the way they talk about it is this is a David versus Goliath battle, Martin. We are taking on the big bad insurers. We are a little freestanding emergency department. We are providing access to high quality care for patients in these communities. And we deserve to get paid a fair price for that rather than being crammed down by payers in these markets. And to me, it's a fascinating case study in healthcare innovation and how we ascribe whether or not things are good or bad to it. Because on the one hand, I think you and I both could sit here and articulate a narrative for 5 or 10 minutes about how Nutex Health is this amazing new startup in healthcare. It's building micro hospitals that are providing access to patients in communities across the United States. Like that is a needed thing. We need more of that. On the other hand, you can also point to the fact that they are doing that by charging 1,000% of Medicare rates. And that seems much more problematic. The results are really good, by the way, right? Like in 2025, they grew revenue 82% and they have an adjusted EBITDA margin of 30% right now. Those are wild financial results, Martin. And
It's great.
Yes.
And you throw micro in front of it, and you got like micro schools. It's just like the perfect. It's like
It's the right trend, right?
wouldn't go after us, a little micro hospital. We're just a micro hospital. We're just a
I
little
know.
guy.
I know. Did you see the quote from the state senator that I included in the
Oh
newsletter? What was your
man, I love
reaction?
a state senate quote. So right, like if you're a state senator in Idaho, I'm not sure exactly about Idaho's Senate structure, but a lot of these states, being a state senator is a part-time job. You get paid like 30K a year. You show up 30, 60, 90 days a year, and then you go back to doing whatever in Idaho, I assume cattle ranching or something. And so the state senator, Brian Lenny, says that's great if that's what they want to provide in the market and you have consumers who are willing to pay the price for it. I don't think they're a bad actor. I heard on the Senate floor that we're capitalists, but here we are trying to shut down this one business. What are we doing? If somebody wants to get a pregnancy test there, they should knock themselves out. Well, Senator Lenny, I have some bad news for you about how insurance works. If you are paying, so a pregnancy test at a micro hospital slash ER is uh, usually not just like 1,000 times of what you would pay, but like if you just go to a CVS and buy a pregnancy test, which is usually what they're giving you at the micro hospital, it's like a couple of bucks. And at a
Mm-hmm.
micro hospital, I don't know exactly what they're charging. I'm gonna guess it's like 1,000.
Mm-hmm.
Sweet, sweet business to be in. So yeah, I think like this is a little bit indicative of the problem here, which is that Senator Lenny doesn't have, I think, maybe the full set of facts here, and he's getting briefed by his part-time, legislative assistant who's saying like it's a free market. And you're like, well, yeah, but also they're abusing the IDR process. They're maybe not acting in good faith. Should we charge
Yeah.
$1,000 for a pregnancy test? I don't know. Is that
Yeah.
reasonable?
Yeah. You start thinking about commercial insurance rate increases in the market. Like when I hear him saying that quote, I think he is assuming this is just cash pay out of pocket. It's not impacting anybody else's healthcare costs. But it does. And that's the
Oh,
issue,
yes.
right? I mean, this is a problem. And I don't know.
It's a big problem.
To your point on other jobs, I was looking up Mr. Lenny over the weekend. He is also a children's book author. He's written two children's books. You want to guess the title of those books? I'm going to mention them and we're going to move on.
Please do. Please let me know.
The apparently better known one is Why Everyone Needs an AR-15, A Guide for Kids. Book one. Book two, Why Feminism is So Silly, A Guide for Kids.
Okay. I don't really have anything I feel comfortable saying
That's
on the
the top
record.
of his Wikipedia page. Yeah,
Well,
I
good for
just
him.
I
There's a
yeah.
niche for everyone in the
Yep.
children's book market. Okay, let's do a quick tour of what happened this week in the private markets. Big,
Yep.
big round or announcement from TPG investing in Find Help. Kevin, what's Find Help?
Find Help is one of the platforms that coordinates access to social services, I guess, broadly speaking. So
Upstream
they
drivers of health is what we're calling
upstream
them now.
drivers of health. Yes, that is the accountable health communities parlance today, right? Uh, cool platform, needed platform from my perspective. Seems like good infrastructure to have to connect folks who need it with the resources around them and the communities that they exist in. Always has seemed like something of a challenged business model to figure out how to make that work, right? Like that was one of the accountable health communities part of that test of can you bring these startups in and these platforms to help connect people with those services. Interestingly, in the announcement, Find Help also noted it is getting into eligibility determination for Medicare and Medicaid, which I can't help but wonder if you're, if you're an analyst at TPG underwriting the financials for this deal, and Martin, you've talked about Equifax and other organizations that are seemingly doing well financially off of the opportunity and eligibility checks today. I can't help but notice that sentence in the press release and be like, I wonder if that is part of the financial opportunity for an organization like this. Will be interesting to keep an eye on.
The other thing I'll mention is that TPG recently did a very large buyout of SureScripts,
Yep.
which is another sort of platform style business. And the interesting thing to me is that if you're a platform style business, you kind of need the market to be winner take all for it to be economically meaningful. And I think it was $250 million was the financing or was the buyout.
Yep.
This would make, the social services platform, I think the largest, like at least in terms of valuation, the largest of these attempts. And so I think the play here is it's going to be the SureScripts of this world, which is something we talked
Hmm.
about at SureScripts all of the time. We said like, okay, there's a many to many problem. This looks functionally the same as the pharmacy provider insurance problem. And with the eligibility, maybe they've found the business model to make it make sense.
Yep. Yeah. Will be fun to watch. Tell me about Greater Good Health last week.
So disclosure, I used to work with basically a lot of the Greater Good Health team when I was working for DaVita Medical Group. And so I've been following them pretty closely, but they announced a Series B 20.5 million in funding led by Illumia Ventures and then a 12.5 million venture debt facility from HSBC. Greater Good's an NP led care model focused on Medicare Advantage. The things I find interesting about it are number one, they are focused on this like care quality, care management as a service model. So this is like business line number one for them is they work with a payer or a plan or a value-based care provider, like DaVita. They were a strategic investor in this, and they say, we're gonna kind of stick our NPs on here to help close gaps in care, do care management, and we'll charge you a PM for that. It strikes me as a good business model to be in right now, given all of the tumult in the MA market. If you are really worried about your star scores, like this is an investment that I think is kind of a no-brainer. But what I find much more interesting is their second line of business. So they've partnered with a couple insurance companies, Humana in Montana, but then also our friends Blue Cross Blue Shield of Idaho, to open de novo clinics in areas where there just is a provider shortage. And the insurance company is paying for the build out of the clinic. They are exclusive for Medicare Advantage with those clinics, but they're also allowed to see traditional Medicare patients. And they're staffing them with PAs and NPs. The markets are, Idaho and Montana, so we're not talking crazy expensive. And it seems like an interesting way to get doctors to these or providers to these rural communities.
Yeah, can't argue with that. That has been ongoing thing for us how to answer that question. It's cool to see models like that emerging.
The other big piece of news this week in private markets was the end before it even began of the big New Mountain Capital spinout from Matthew Holt.
Yeah, I was bummed to see that news. To me, there's not a lot of companies that have a legitimate opportunity to be really big platforms in healthcare, and Thoreau seemed like one of them, stitching together the assets that it was planning to. So going back a few months, Thoreau was planning to spin out AI assets out of New Mountain Capital. New Mountain Capital itself, a lot of those AI assets that had recently acquired in the last couple of years, stitching together businesses into Datavant, Smarter Technologies, and a few other businesses. It was set to be a really interesting AI platform trying to automate the infrastructure transaction layer of healthcare. That is a thesis that makes a ton of sense to me. At the time when the news first came out, New Mountain Capital had sent out a letter to its investor base saying, "We've reached terms of a deal. Here's the general construct of it. Matthew Holt will leave New Mountain Capital." Matthew Holt kind of orchestrated all of those deals for New Mountain Capital. And it's a great way for us to capture upside in these businesses moving forward and for Matthew to lean in on this bet around healthcare AI. Apparently, the deal terms didn't materialize as expected, right? So by the deadline date, Thoreau submitted an offer, Matthew Holt submitted an offer to New Mountain Capital that had some terms that weren't originally anticipated, in part because it seems like the credit market was harder to convince than first anticipated when the deal was announced. And New Mountain Capital basically said, this is too much of a distraction for the ongoing management of these companies. We're calling the deal off and we're going to move on with these companies in our portfolio. Kind of we're still excited about them too, by the way. Like there's still upside in here for us. So let's go run with that. Which makes a lot of sense still, right? Like all of these companies in the New Mountain portfolio, be curious to see what New Mountain does, if anything differently coming out of this failed transaction. But big swing and a miss, in part because it seems the choppiness of the private markets in 2026. And I think to me, that's the broader takeaway here and the interesting thing to keep an eye on. I'm curious to see what this means for kind of that big late stage private equity type market financing opportunity.
Yeah, in the broader non-healthcare markets, there's been, I mean, I think people are calling it a SaaSpocalypse, which
Mm.
nothing you can do about that name. But you look at private credit companies, Blue Owl, BlackRock, Blackstone, And all of them have these publicly traded or quasi-publicly traded business development companies, which are just kind of stuffed with private credit loans. And they are getting lots of requests for redemption. People are just jumpy. It's a jumpy market. It's a jumpy market on the equity side, and it's also a jumpy market on the credit side. And so if I had to bet, and we'll probably never know, but if I had to bet, it was more about credit than anything else.
Yeah, that rings true to me.
So where I want to finish is you had a great interview this week with the Louisiana Department of or Secretary of Health and the CEO of a company called Aradigm about cell and gene therapy. And it made me think about this quote that I go back to all of the time from Atul Gawande, where he talks about how we kind of got fooled by penicillin and we thought that there would be injection for cancer and for heart disease and for a stroke. And it turns out that it's a lot more complicated than that. And when you hear the conversation about cell and gene therapy and you just hear the first part about the cell and gene therapy itself, you're like, oh, it's here. There's an injection for all of these things, and that's it. And it turns out it's actually a lot more complicated than that. We are still in the century of the system, that Atul Gawande describes, where to realize the benefits of those things, it's not really like penicillin at all still, even though it is, in fact, an injection that can solve almost any problem you can imagine.
Yeah. I mean, it's the 60 Minutes episode is well worth a watch and wild to me in this regard. Like, it is very complicated. And we have stories like that episode where you've got a family and you've got a girl who comes out at the end of the episode and is alive at 6 because she had the cell gene therapy treatment at 2. And there was hell for her family to go through to get coverage for that treatment and make sure that um, this girl Macy received it. But man, I was watching that 60 Minutes episode again, preparing for the interview last week, and it's hard to watch without tears. Like being a parent of a young daughter, you put yourself in the shoes of that family, and it's really hard to watch. Yes, it is incredibly complicated, and the rollout of these things is going to be really fascinating to watch because okay, you've got the financing issue, right? Like that's kind of been the general point we've talked about in the community. These drugs today cost between $1 and $4 million per treatment, and that is really hard to sustain, right? There, the 60 Minutes episode also included this really interesting example of CEO of a health system in Missouri who made the decision to not cover cell and gene therapies for their employee population as part of their plan. This is the employer, not the insurer, by the way, that makes that decision. And they had one employee who had twins who needed this cell and gene therapy treatment. And it was going to be $4.2 million, I think was the rough ballpark number. And the employer said, no, we're not covering that treatment. It's going to cause costs to go up too much for the rest of our employee plan. CEO started getting death threats because the family went public with the fact that the employer wasn't covering this. CEO had to send their family out of state to keep their family safe. And CEO then started appealing to local donors and ultimately the state Medicaid agency to pay for this coverage. And the state Medicaid agency foot the bill. So state Medicaid paid the $4.2 million for those two kids to stay alive. Really hard situation to unpack. You put yourself in the shoes of that CEO and how you evaluate those trade-offs and what you do. Like I can understand why CEO of that health system is saying, we can't afford to cover this for our employees. I also can understand why that family is going public, being like, what the hell? We need this treatment. And then I can understand the conversations that happen where the state Medicaid agency says, yep, okay, we'll end up footing the bill for this. None of that seems sustainable. It seems like a really hard example of how all of this plays out. And that's just on the financing side. That's before you get into all the complicated nuance of one of the other things that fascinates me in this. These drugs the CEOs of the companies talk about the fact that these drugs take 10 years to develop and cost $3 billion to develop. And Will Schrank in the interview is like, yeah, and they're still only tested on, a few dozen people to get through approvals. So when they get to market, we don't actually know what's going to happen with them. We don't know the side effects. We don't know what happens in the real world. And there's this whole infrastructure that we're going to need to build to understand the quality, to help clinicians understand how to provide these treatments, to actually build the clinics that can do them. There's another startup that raised funding this week. What was it called?
Next
New
cure.
Next Cure, that raised something around $20 million to build out the clinic infrastructure for CAR T therapy. On the raising the point in their press release that only 200 out of the 6,000 hospitals in the country currently have the ability to deliver CAR T therapy. Like there is a whole infrastructure that's going to be needed to build out these um, for the delivery of these therapies, and it's going to be fascinating to watch. I think, Martin. I'm curious to see how it evolves over time.
Yeah, I think the financing, the operations, the delivery, that is the story of the
Hmm.
next 10
For sure.
years.
It was
And
it was nice to hear a state leader talking about how they are proactively thinking about, like at the beginning of the interview, Bruce Greenstein's like, it's not a huge cost driver for us today, right? There's only a few of these cases. It's if you think about the overall budget for Medicaid in the state of Louisiana, it's not huge at the moment, but we can see it coming. I think there's 4,000 of these drugs in the pipeline right now, which is just mind-boggling to me. 30 of them are approved. Gruber talked in 60 Minutes about Jonathan Gruber, ACA architect, how it's this coming tsunami. Because one of the points he makes is, and tying it back to your Atul Gawande clip, like right now it is for rare conditions, largely for kids, right? That's why it's a big deal for state Medicaid agencies. But Gruber's like, at some point, this is going to cure cancer. At some point, this is going to cure heart disease. And we're going to have to grapple with how we afford societally paying for that for mass markets of individuals. And it's wild to think about. Last point I find really interesting on this topic. To your point on this being the wave over the next decade, I very much agree with that. We've kind of had this ongoing theme of last decade, VBC, key topic of conversation this coming decade, specialty pharmacy innovation, and specifically CGT as key driver of that. If you think about the implications for value-based care models, I think it's interesting to try to work through that. Like we've seen in oncology where drug spend has taken up the vast majority of total cost of care, how that results in a very different model, right? I talked with John Kao at Alignment in an interview last week and brought up oncology. It's like we treat oncology very differently than other disease states. And I think it'll be fascinating to see as these therapies move to other disease states too, what that implies for the management of total cost of care. We saw Cigna back in 2024 talking about this at their investor day, where you've got total cost of healthcare going up drastically between 2024 and 2026 in their investor day slide, driven by RX spend going from 25 to 30% of the healthcare dollar to 40 to 45% of the healthcare dollar. If more of the healthcare dollar is in RX spend, how do you manage total medical spend to drive savings that you need as a value-based care model? I think that's going to be a really interesting question to unpack and keep an eye on over the coming decade in all of this.
that feels like a great place to leave it. What a start to the week. We'll be keeping on top of all of these things and more for the next time we come and chat with you a week from today. Thanks for your time this morning, Kevin.
Likewise, see you, Martin.
Bye.